Pharmacokinetics refers to the movement and modification of a medication inside the body. In other words, it's what the body does to a medication and how it does it. Okay, first things first. A medication needs a way to be administered or a route of administration. Depending on the form of the chemical preparation, like a pill, solution, spray, or ointment, and the part of the body being treated, the medication can be administered through various means or routes, such as swallowed by the mouth or orally, injected into a vein or intravenously, injected into a muscle or intramuscularly, inhaled into the lungs, sprayed into the nose or nasally, and applied onto the skin or cutaneously. Once a medication is administered, it first has to be absorbed into the circulation, then distributed throughout the body, metabolized or broken down, and finally excreted in the urine or feces. This process can be broken down into 4 components with the acronym ADME, which stands for absorption, distribution, metabolism, and excretion. Now, the loss of drug through chemical metabolism, which makes it inactive, and through physical excretion out of the body, can together be referred to as elimination. Okay, so let's start with absorption. Absorption is the process of moving the medication from the site of administration into the circulation. With the exception of intravenous administration, a medication will need to cross one or more cell membranes before it reaches the circulation. Movement across the cell membrane can occur via passive transport, which requires no energy, and active transport, which requires energy in the form of adenosine triphosphate, or ATP. 2 types of passive transport are used: facilitated diffusion and passive diffusion. Facilitated diffusion helps larger, water-soluble, and polar medications move across the membrane through transport proteins like channels and carrier proteins. Passive diffusion helps small, lipid-soluble, and nonpolar medications move across the membrane from an area of high concentration to low concentration. But sometimes active transport is needed, meaning that the medication is transported against their concentration gradient. This involves specific carrier proteins that use ATP as a fuel to pump medications into the cell. Now, sometimes medication molecules are so large that the cell resorts to bulk transport, also known as endocytosis, where the cell membrane invaginates and swallows up the medication, forming vesicles. Now, the rate of the absorption, or how quickly this process occurs, as well as the extent of the absorption, or how much of that medication reaches the bloodstream, depend on several factors. One of them is the pH of the environment where absorption takes place. Okay, so most medications are either weak acids or weak bases, and can exist in an uncharged or charged form. The uncharged form is the lipid-soluble, nonpolar one, which happily diffuses through the cell membrane, while the charged form is water-soluble and polar, and thus cannot diffuse through the cell membrane easily. The ratio between the 2 forms is determined by the pH of the environment and the strength of the weak acid or base. The strength is measured by pKa, which is the pH value when concentrations of the uncharged and charged forms equal each other. So, when the charged form of a weak acid, A-, shows up in an acidic environment with a lower pH and plenty of hydrogen H+ ions around, it will grab one of them and turn into its uncharged form, HA. HA can then be readily absorbed across the cell membrane. On the flip side, if the charged form of a weak base, BH+, is placed into an alkaline environment with a higher pH and a lack of hydrogen H+ ions, it's going to give up its own hydrogen H+ ion and become an uncharged B. It can then pass through the cell membrane just like HA. So in other words, weakly acidic medications will be better absorbed in an acidic environment, like the proximal duodenum, in contrast to weakly basic medications, which are more likely to get absorbed in an alkaline environment, like the distal ileum of the small intestine. Note that even though the stomach is acidic, it's not suitable for the absorption of even weak acids, mainly because of its thick mucus layer. Okay, now another factor influencing absorption is the surface area available. A good place for absorption is the small intestine. With its circular folds, villi, and microvilli, the total surface is actually about 250 square meters, the size of a tennis court. Other factors also include the blood supply to the absorption site and the presence of food or other material in the gastrointestinal tract that can either promote or inhibit absorption. So, after a medication is taken by mouth, it gets absorbed through the walls of the small intestine and transported into the liver via the portal vein. Once in the liver, hepatic enzymes work on the medication to metabolize it. This process is known as first-pass metabolism or first-pass effect and is responsible for breaking down most medications into their inactive metabolites, as well as converting certain prodrugs into their active metabolites before entering the general circulation. This, however, means that if a medication is taken orally and it undergoes extensive first-pass metabolism, their concentration in the bloodstream can get so reduced that once they reach their site of action, they can't produce the desired effect. In that case, alternative routes of administration should be considered, including intravenous, intramuscular, transdermal, sublingual, or inhalational administration. What these do is bypass the first pass effect, allowing medications to go straight into the systemic circulation and produce their effect. Okay, so this brings us to the concept of bioavailability. Bioavailability, or F, is actually the fraction of an administered medication that eventually reaches the circulation in the unchanged form. For example, if someone takes 100 milligrams of pantoprazole orally and only 77 milligrams of this is absorbed into the circulation, the bioavailability is 0.77 or 77%. In contrast, if the same 100 milligrams pantoprazole is taken intravenously, all of it goes directly into the circulation, bypassing the gastrointestinal absorption and first-pass metabolism. So medications administered intravenously will always have a bioavailability of 1 or 100%. Let's plot all this into a nice graph to show the relationship between time on the x-axis and the plasma concentration of the medication on the y-axis after both oral and intravenous administration. Thus, bioavailability of an oral medication can be estimated by dividing the area under curve, or AUC for short, of the oral form by the AUC of the intravenous form. And both AUCs need to be corrected by the dose of medication, or D for short, administered orally and intravenously. So the bioavailability F of a medication is AUC oral times D intravenous over AUC intravenous times D oral. Alright, so once the absorption has been completed, we are ready for the distribution of the medication. Distribution is the movement of a medication from the circulation into the body tissues. Once again, the rate and extent of distribution depends on several factors. So one of them is blood supply to different tissues. Medications will be more rapidly distributed to body tissues that receive large amounts of blood supply, like the brain, liver, and kidneys, and less to the tissues with poor blood supply, like the skin and adipose tissue. But for any medication to enter the brain itself, it has to go through the so-called blood-brain barrier, which is strictly regulated. Think of the blood-brain barrier as the brain's bouncer, a highly selective membrane that turns away large, water-soluble medications that are floating around in the blood, while letting in smaller, fat-soluble medications. Similarly, the size and polarity of a medication affects its distribution. So in general, smaller, hydrophobic or lipid-soluble medications can easily cross through the lipid bilayer cell membranes, giving them an extra edge in distribution over large, hydrophilic or water-soluble medications. Another factor affecting distribution is the degree of plasma protein binding. Medications travel through the bloodstream partly bound to plasma proteins like albumin and partly unbound or free. But only the unbound fraction is free to diffuse into tissues, whereas medication molecules that are bound to plasma proteins remain limited to the plasma, acting as a kind of reservoir. That's why medications with lower plasma protein binding, such as gentamicin, get distributed readily in the tissues, while medications with higher plasma protein binding, such as warfarin, take much more time to free themselves and diffuse, thus giving them a longer duration of action. Finally, an important concept is the apparent volume of distribution, or VD, of a medication, which is used to represent how extensively a medication is distributed throughout the body. It is the hypothetical volume that accommodates all of the medication in the body if the concentration throughout was the same as in plasma. Let's simplify this with an example. Let's say we inject 100 milligrams of a medication into the blood and none of it is excreted. Then an hour later we find the plasma concentration is 50 milligrams per liter. To calculate the apparent volume of distribution, we need to divide the dose administered intravenously, in milligrams, by the plasma concentration of the medication in milligrams per liter. So we get 100 milligrams over 50 milligrams per liter to get a VD of 2 liters. The thing here is that we assume that the medication is distributed evenly throughout the body, although that's not the case for most medications. So, smaller, lipid-soluble medications can cross cell membranes easily, so they get distributed in extravascular body tissues, organs, and fat cells, while medications that are larger and water-soluble stay mostly in the plasma. In any case, it's safe to say that medications with a rather small apparent volume of distribution, or VD, such as 3 liters or less, remain mainly in the plasma. Medications with an apparent volume of distribution, or VD, of 16 liters or more get distributed throughout the extracellular fluid, meaning both the plasma and interstitial fluid compartments. And medications with an apparent volume of distribution, or VD, of 46 liters or more are possibly distributed throughout all body compartments. Now, there are certain situations where this apparent volume of distribution may get altered. For example, in chronic liver diseases like cirrhosis, where the liver is unable to produce enough plasma protein, or in certain kidney conditions like CKD or chronic kidney disease, where excess amounts of plasma proteins get filtered out through urine, the amount of plasma protein-bound medication gets reduced substantially, therefore increasing the VD. Alright. As a quick recap, absorption refers to the movement of medication from the site of administration into the circulation. It can occur through passive diffusion, facilitated diffusion, active transport, and endocytosis, and is determined by the route of administration, the pH of the environment, the chemical properties of the medication, the surface area and blood supply of the absorptive surface, the amount of contact time with the absorptive surface, and the presence of food or other medications in the gastrointestinal tract. Bioavailability is a measure of the absorption, and distribution is the movement of a medication from the circulation into the body's tissues, which depends on blood flow to tissues, size and polarity, and plasma protein binding. The apparent volume of distribution, or VD, is a measure of the extent of distribution, and it can be affected by certain kidney and liver conditions.
Helping current and future clinicians focus, learn, retain, and thrive. Learn more